All right, so let's pick it back up with portal hypertension. So this is one of the big complications of cirrhosis, right? Cirrhosis has many, many symptoms, many, many complications, but portal hypertension is one of the big ones, right? So portal hypertension is where you have a sclerosed cirrhotic liver that the blood cannot get through. So here's a normal liver right here, and we have a cirrhotic liver that fluid can't get into, right? So all that fluid backs up. All that fluid backing up is going to engorge those portal veins. So you can see here, all this fluid is trying to make its way into the liver, and all of it then just backs up, and the pressure increases. So we got esophageal engorgement. We have gastric engorgement. But we have a better word for engorgement. We call that varices, right? When a vein gets engorged, it becomes variceal, right? So we have a gastric vein, splenic vein, and we talked about splenic veins. When they get engorged, it also, all that fluid will back up also into the organ itself. The spleen causes splenomegaly, and the splenomegaly leads to coagulopathy, right? Hold on, just let it catch up there, okay? And then we have the gastric vein. So the gastric vein will back up, and there's an esophageal component as well, and we get esophageal varices. You can have rectal varices, right? If all that fluid backs up into the umbilical vein, now congratulations, now you have a new umbilicus, right, or umbilical vein pattern, right? So that all backs up there, and you can actually see it on the skin. They call it caput medusae, right? So all that's, it looks like the head of Medusa. And then we talked about on the face or the skin, usually on the face or the head, we have little spider angiomas, which are a sign of fluid or blood that's backing up into the tissue, okay? And the more of those that you have, the higher risk you are of having varices that might bleed, right? Normal pressure inside that system is about 6, right? That's normal central venous pressure. And then that starts getting higher than 12, you're starting to have complications. The veins are not a high pressure system. They're not designed for high pressure, right? So all that blood flow backs up into the veins, and then we have all this engorgement happening. So that's a problem, that we have all this blood that's all backed up into the veins, but then the portal circulation is like, I know how to fix it. I'm going to release some vasodilators. Because if you vasodilate, if I release some vasodilators, they're going to go up here and they're going to vasodilate the liver vessels. Little do they know that the liver is cirrhotic and it's a wasteland, right? So where do the pulmonary vasodilators go next? If they can't go forward, they're all going to back up, or some of them might squeak on through, and it's going to cause widespread systemic vasodilation, right? And it's only going to vasodilate itself, so it's going to plate itself, trying to release vasodilators. If you vasodilate itself, now more fluid can now back up into the portal circulation. So it's a twofold approach. These patients are chronically hypotensive because of the portal circulation trying to fix the problem. And also they're chronically engorged because of the problem to begin with, but also the fact that they're releasing all of these vasodilators that are causing more issue than good, okay? And then on top of that, we have low circulating volume. We talk about low circulating volume to the kidneys and to the baroreceptors, right? Causes the SNS and ADH and RAS to fire off. And with all of those firing off, because the blood volume is poor, those are trying to fix the problem by increasing volume. And little they know, the volume will get increased, but it's all going to go to the place where the vasodilators are at, which is the portal circulation. So all that fluid just backs up into the portal circulation, and the veins get even more engorged. Okay, and as a token of goodwill, we get hyponatremia because of the action of those things, right? And to find out, we're going to give medications that are going to block aldosterone, right? We're going to give medications that are going to block the vasodilation that's happening, right? With beta blockers, all right? So that's the idea, all right? So we have a decreased effective arterial blood volume, and that blood volume is decreased in the arterial system because all the blood is where? It's in the portal circulation, right? You're trying to restore it, but you're not making albumin either. And you're not making albumin, where's the fluid going? Into the belly or into the interstitial spaces. So we have decreased circulating volume, and now our kidneys, they try to release RAS to restore volume, but eventually you're going to get hepatorenal syndrome because of this, where the kidneys die because of the liver dying, hepatorenal. Okay, so our vessels are super swole in the portal circulation. All right, so how do you fix it? There you go. So how do you fix it? All right, so treatment and complications. So our goals are to reduce the blood volume inside the portal circulation. So how do we do that? We can give non-selective beta blockers that are going to block beta 1, beta 2, and alpha receptors. And that means they are not what? They are not man-babes, right? Because man-babes are beta 1 specific. We want to fix the vessels, right? We want to prevent the vessels from vasodilating, right? And also, when we give an alpha 1, you're like, well, shoot, alpha 1, I thought that vasoconstricts. If I give a beta blocker that blocks the alpha 1s, that should vasodilate. That's going to make it worse. Well, you're actually going to vasodilate the liver. So you can actually, all that tight liver vessels, you're actually vasodilate those. So it actually is beneficial in that regard. And also, you dilate the alpha 1 areas elsewhere. So all that blood goes to the periphery instead of to the gut. Okay? And then beta 2, you can see, is going to vasodilate, it's going to stop the vasodilation in those areas and allow a reduction in blood flow from entering the portal circulation. Okay? So hepatorenal syndrome we mentioned, right? That can cause all those vasodilators that the portal circulation thought it could help. It says, oh well, shoot, if I'm not getting circulation, via that liver, how about I release some vasodilators to make it work? And they don't work, and they leak on through, and they cause a kidney poor flow to the kidney. Okay, and then ascites, we have low albumin, therefore we have low volume states. And that can lead to more problems, and we have to pull out all that fluid from the belly. And that's called a paracentesis, right? And we have to replace albumin. So when you give albumin nowadays, it's usually for liver complications, right? So one of those complications is ascites. Another complication would be hepatorenal syndrome, to restore volume. Another reason would be SBP. So those are the three reasons you would give albumin. So albumin, we give it for SBP. We give it for, what did I just say? For large volume paracenteses. And you give it for hepatorenal syndrome. So that's when is albumin indicated? It's indicated in these areas. Okay. And then we get to variceal bleeds. So you see here the varices, those vessels are full of fluid, right? All full of blood, and they're just ready to pop. So you can see here is a scope of a varice. Eventually, there we go. So you can see how those vessels are all engorged, sort of. Sorry, we're on Wi-Fi here, and it's not working great. There's a still image of varices, right? Will it catch up? Let's see. My internet connection is unstable. Let's play it again from over here. I think I better look before over here. So there's one more time. So I'm trying to get optimal Wi-Fi. I'm not sure how we get optimal Wi-Fi. You see there's a bleeding varice right there, right? So they're going in and out. They're trying to find the bleed, and they're going to intervene in that bleed. You can see the esophagus should be nice and smooth. There aren't rugae or haustra inside an esophagus, right? All right, once more for good measure. It takes 3 times to play video. I think I found a good Wi-Fi area. All right, so they're going to go in there and they're going to find the bleed. So that's the bleed at 3 frames per minute. So you can see it's just oozing out, right? That's a variceal bleed because under high pressure, right? So there's a little bit of bleeding, and these guys are going to have what kind of GI symptoms if this is the esophagus? See that there's They're just going to cough up that blood. They're not really cough it up. They might be coughing, but they're going to be retching that blood, right? It's going to fill up really, really quick. It's bright red blood per mouth, which is called what? Hematemesis. Okay, so that is a complication, and also if it's that fast, it can make its way all the way through the GI tract, and it can come out as bright red blood, right? Whenever it's a really, really fast bleed, it can lead to a bright red blood per rectum, or hematochezia as well. Right? It's only slow bleeds that lead to coffee ground emesis or melena.
Life is good! This is fun! My anus is bleeding! My anus is bleeding! For the love of God and all that is holy, my anus is
So it can be a bright red blood per rectum, right? All right, so esophageal varices are due to increased fluid inside that portal circulation, right? Due to several different factors.
Life is good!
Okay, so how do you treat it? How do you treat a variceal bleed? So ironically, you give antibiotics. It's like, well, what the heck? Why am I giving antibiotics to someone who's bleeding? Are they get infected with the bacteria? Yes, that's what happened. So they have there we go. So they have a vessel that is leaky, right? So vessels get leaky when you get, like when you stub your toe, you create a whole bunch, it gets swollen, right? And why does it get swollen? Because all the inflammatory mediators down there are going to cause the vessel to get leaky. So all the fluid can leak there and dilute out the bacteria, and also allows your big old white blood cells to come on through to that area and fight the infection. But when you have a systemic infection, you have you have a bacterial infection in your bloodstream, or you have a really bad infection, that's going to cause all the vessels, not just your big toe, but all the vessels to get leaky. So that includes your esophageal vessels, that includes your rectal vessels, that includes your GI tract vessels. So you're at risk for bleed when you have an infection. That is what's causing these bleeds. These bleeds don't open up due to trauma. They open up because of an infection. So you have to give antibiotics as part of your the plan for someone that has a GI bleed due to varices. A peptic ulcer disease, no, you don't need to give antibiotics, right? It's not because of a vessel that got leaky all of a sudden. A vessel that's about to pop and it gets leaky, that's a esophageal varice or a gastric varice or a rectal varice. But like a peptic ulcer disease, that's just eating away at the layer until it just starts oozing, right? So here's an example of a peptic ulcer here. Hopefully at a faster frame rate. Let's find out. All right, so they're going into the stomach there. I think that's the distal pylorus, actually. And you see how it's just nice and oozy, right? So they're going there, they're going to grab it, and they're going to put clips. They're going to clip each side of the vessel and pinch off the blood supply to that ulcer, right? So you see it's oozing. It's a pretty good ooze there, right? That's the ulcer bed. They're going to might give a little saline flush to wash it off, and then they're going to apply clips. All right, so you can see the top middle there. They clip it. They clip each side, and they're literally just pinching it off, right? Whereas here's an example of clipping, actually. I can get it to play. So here they put the clips in place, and they little saline flush, and now it's not bleeding anymore. They clipped off the vessel on both sides, and now it's not oozing, right? Well, it's oozing a little bit there. So you got to hire another GI doctor. And then you have a bleeding varice. As we saw before, a bleeding varice, you can't really just clip to engorged vessels. What is that going to do? All right, so what do? You put a little hair tie over it. Did I click the right one? I did not. Let's see if I can click the right one this time. So that one's still oozy. So bleeding varix. Nope. It's like one of those games. I'm going to make it lower next time. There we go. So that's just oozing and oozing and oozing. The varice is swollen and it's just oozing blood. Okay? So you can't just clip both sides. It's not going to work. You got to put a rubber band around it and cinch it off the hole. Okay? So that's the idea. You band varices and you clip ulcers, basically. Okay? So antibiotics and then blood. You will give blood if the doctor's down in LA and he has to make his way 40 minutes to get here and the patient's bleeding out. But if I give blood, what's going to happen? It's all going to make its way into the portal circulation and we're just going to bleed more. We're just going to bleed it out at that rate. And does your pump infuse that fast? It might. 99 per hour, it's probably going to look like that, right? If you're pumping your blood in just as fast, right? So you have to give, you will give blood transfusions to stabilize their blood pressure, but really the priority is what's highlighted there, right? Is the EGD. You need to get the guy in there and they need to scope. They have to be MPO for 4 hours. Don't care, right? We're going to go in there, we're going to clip it, or not clip it, we're going to band it right away, right? So an EGD is the priority. To call a GI doctor to get the patient banded, right? And this is and they're going to do an upper GI bleed, an upper endoscopy, an EGD, not a colonoscopy. And they're going to do EGD even if they have bright red blood per rectum. So you're going the wrong hole. It's like, no. They're bleeding at such a fast rate. Usually when you have a really fast bleed, you have bright red blood per rectum, and the patient looks super sick, it's probably an upper GI bleed. So they're always going to get that first, just in case. Because as far as odds go, it's more common to have a really, really fast bleed in the upper GI system, not the lower GI. It's possible, but it's rare. Okay, and then octreotide. Octreotide is a vasoconstrictor of the GI tract. Basically, it inhibits all those little vasodilators that the body is trying to do to fix the situation. It stops that from happening. It's a splanchnic vasoconstrictor, right? It inhibits all of the GI tract, so they're at risk for hypoglycemia also. Either way, vasopressors. That's usually our priority. We don't give fluids for this person because all the fluids are going to make their way to the portal circulation. So giving fluids and blood is not great. We should be giving vasopressors, right? I think some examples like norepi, vasopressin. All right, and then salvage therapy. So they tried the EGD and not working. So what do they do next, right? Because they couldn't band it and it's still bleeding and still oozing. Well, we have what's called a balloon tamponade. It's like an NG tube on steroids. So you throw the NG tube in there, and does the NG tube going to cause trauma? No. So it's a old wives' tale or an old GI wives' tale, where they say, don't put NG tubes in my patient because they might bleed. It doesn't bleed because of damage. It bleeds because of a infection, right? So we're going to, that's not a marker, hold on. So it's going to, we're going to put a balloon into their throat, and we're going to put a balloon, you're going to inflate it in the gastrum. Okay, so we're going to inflate it, and then we're going to pull this. See, it's coming out of the patient, and we're going to put it on a 1 liter traction or 1 kilogram of traction. So you're literally just stopping the bleeding, right? And also, if that doesn't do it, we can inflate a balloon in the esophagus to also tamponade the esophagus from bleeding. So it's a temporary measure, right? It's a cruel, barbaric way just to stop the bleeding physically, right? Obviously, it can cause ischemia if it's on there for too long. So usually, it's only 24 hours, right? So times 24 hours, you do that. And then they pretty much need a definitive intervention. They might rescope them. They might go to the EGD the next day, right, or 12 hours later. But usually they have to go to get what's called a TIPS procedure. So TIPS reroutes the blood from the high portal hypertension circulation and puts it into the venous circulation. So it's called a transjugular intrahepatic portosystemic shunt. So it goes transjugularly. They put a catheter in the jugular. They go into the liver, and they go right through the liver, right? And they put a little shunt between the high circulation over here into the lower circulation in the vena cava, right? So it reroutes the blood from the portal circulation into the central circulation. So it's really it's a shunt. It's rerouting the blood, right? It's like a detour. Okay, so that's a TIPS procedure. So it's for someone that has really, really advanced varices that you can't fix with an EGD. Okay, you can't go to surgery with these. You can't just take out that piece of the gastrum or that piece of the esophagus. They're coagulopathic to begin with, right? It's not going to work out great. All right, any questions on how that works and the process for a variceal bleed and how to treat it, what to expect? Yes. It goes through the jugular vein, right, down the superior vena cava into the inferior vena cava, goes the hepatic vein through the liver into the portal circulation, and then they put they leave behind a plastic shunt, right, and it reroutes blood from the portal circulation up into the central circulation. Okay, so you can see here they're putting a band around the varice, all right, and then what's left over is a little ligating band. That was the same treatment we did for hemorrhoids, right?